onset when the symptoms started, okay? And then we get a PT INR usually, but that's not, you know, super emergent right before everything happens, but that's something that they usually get. Okay, so before we give nitro, we need to have a really quick powwow about what you need to have before you give nitro, okay? So the reason that they've kind of steered away from the MONA acronym is because, and this isn't going to be you guys, right, because I'm teaching you, but because we tend to look at that and do it like a checklist, right? So we're like, oh, okay, morphine, oxygen, nitro, aspirin, and we don't really think. Okay, well, there's some certain circumstances where you can't give nitro, and so they don't want people giving nitro under these circumstances. So for that reason, they've kind of broken up the MONA acronym, okay? And we want you to use your brains and think about it, okay? So before we give nitro, we absolutely, positively need some things. So we need a blood pressure. Why? Well, because nitro, because it's a vasodilator, it lowers blood pressure. So consequently, we cannot give it if blood pressure systolically is less than 100. Right? And there have been times when I've given nitro at systolic of 110, and then they tank to 70 systolic. So, you know, you have to really stay close to your patient and really be aware, because their systolic might be totally fine, but guess what? Then you don't know how it's going to affect them, and it might tank them. And if you don't have an IV, then you can't fix it. So we need an IV, because if the blood pressure is too low, how do we fix low blood pressure? Well, in most people, we give an NS bolus, or IV bolus, right? We'll just say IV bolus. We give an IV bolus to fix hypotension, unless they have, you know, crappy comorbidities and CHF and all kinds of stuff. But even if they have heart failure, we can give them a 250 ml bolus, and then, you know, supposedly they can handle that, right? So we need to fix, if it lowers their blood pressure, we got to fix it with IV bolus. Okay, so, and then we need to hold that nitro for a few reasons. If that EKG comes back and it shows that it's an inferior infarct, meaning that they have ST elevation in leads 2, 3, and AVF, and every, you know, whether it's inferior, lateral, septal, all that kind of stuff, it will, you know, you'll have ST elevation in different leads. But with inferior, it shows 2, 3, and AVF, and so we don't give nitro if it's an inferior infarct. Because if it's an inferior infarct and you give nitro, you can potentially completely bottom them out, vasodilate their heart completely out, and throw them into like hypovolemic shock. So we don't want to do that. All right, and then we already talked about our erectile dysfunction meds. So we're going to hold the nitro if it's an inferior infarct, hold the nitro if they take ED meds. So that is our Viagra, Cialis, and there's a bunch of generics, right? So all of our ED meds are going to hold your nitro. Okay, so let's talk about the sequence of events and how it's treated. Because sometimes it gets a little confusing. It's like, well, wait a minute, they have chest pain, but then we send them home. And they're just following up with a stress test. But this guy had chest pain, and he went straight to the cath lab. What's the difference? Okay, so let's explain that a little bit. So ST elevation looks like that, okay? So we have our little PQRST, but it's gone awry. So here's the PQR, and then our ST is now elevated. So instead of looking lovely like this, right? Oh, except that little tail right there. Okay, so instead of it looking lovely like this with our PQRST, right? Now we have our ST is elevated above baseline. So that's why they call it ST elevation. Now, here we go. We're going to talk about STEMI versus non-STEMI. So, if I have a patient with chest pain, okay, we do the first EKG and it shows ST elevation. So we're going to do this side first, this column first. Shows ST elevation. Guess what? These are the easiest patient to take care of ever. Because once you get that ST elevation confirmed by your provider, they will usually be in the cath lab within, 20 to 30 minutes or sooner. So they go straight to cath lab. This is called a Stemi, right? Because on the EKG, they had an ST elevation MI. That's what it stands for. ST elevation myocardial infarction. So that's our Stemi. So they go straight to the cath lab for PCI, where they get stents, right? Okay. Then we got our EKG, folks. So now we got a chest pain patient. We get an EKG within 10 minutes, right? And there's no ST elevation. Huh, weird. Okay, so the first EKG was normal, but we might say that they do have some T wave inversion that could indicate, a little bit of ischemia happening, right? Okay. So we don't have ST elevation, so it's not a Stemi. So these guys are an N-Stemi. So that is a non-ST elevation myocardial infarction. So Stemi, N-Stemi, okay? Then, the reason they call these guys an N-Stemi is you have to have something in order to be an N-Stemi. So you have to have, you don't necessarily have to have the T-wave inversion, but you have to have your first initial EKG was normal, and then your first troponin is elevated. That's what makes them an N-Stemi, right? Because these guys, their EKG was showed ST elevation from the get-go, so they go straight to cath lab, forget them. Now these guys have a normal EKG with maybe some T-wave inversion, and then the troponin is elevated, boom, N-Stemi, then they go to cath lab for PCI, stents, or diagnostic, whatever. Okay, so we'll talk about that in a minute. Now we have, how about this is our third patient. He doesn't have any ST elevation. Okay. He doesn't have any T-wave abnormalities. His EKG is totally normal, or hers. Then our first troponin is within normal limits. It's okie dokie. Okay? So what do we do after that? Well, they do a couple things. Usually we keep them in the ER for 3 to 4 hours more, and we do, or from the time of onset, we do a 3 to 4 hour troponin. And we usually measure that from 3 to 4 hours from the time that it started. Some providers will say 3 to 4 hours from the time they got to the ER. And that seems to be the trend, just because then if it's elevated, they're sure to catch it, if they measure from the time they walked into the ER. So then we do a second troponin. So now we've done our first troponin was normal, EKG was normal, first troponin was normal, 3 to 4 hour troponin, so that's our second one. Let's say the second one was elevated. Then they go to cath lab. Okay? And so that would technically, I'm not sure if that would technically still be an N-Stemi because the first troponin was normal for this patient. So they'll go to cath lab at that point. Now, or they will be admitted to the floor and then go to the cath lab, however they do it. Okay, now, what if we do a second troponin and troponin is normal? Okay? Then we do so let's say our second troponin is elevated on this group. This group, our second troponin, is normal. So then what do we do? Right? So trop is normal. So then they will probably be admitted, depending on their history. And then they will do a stress test. Cool. So they get admitted, do a stress test. They might send them home, just depending on what the patient wants, but usually if they've had a heart attack in the past, or if they have, you know, all the risk factors, then they're going to be admitted and watched, and they'll do serial troponins every 4 hours or so. Okay, now, or it could be every 6 hours. So that's kind of 4 different ways that we treat chest pain. From the time they walk in until they are discharged from the ER, either to cath lab or admitted, or they go home. Okay? So we do diagnostic. So an angiogram is just that. It's just diagnostic. So it's just a look-see. They still do, you know, they will access the radial artery now. They don't do femorals hardly anymore because of the risk of the hemorrhage. But they'll do the radial artery. So they'll still go up there and take a look. But it's no interventions. So this is non-interventional. Okay, so this is just a quick look-see exam. Okay, then interventional cardiologist comes in and does the actual stent placement if they've been diagnosed with a blockage or whatever however they decide would warrant stent placement. Now, one thing we need to understand is why can't they put a stent in if an artery is occluded 100%? Well, because if an artery is occluded 100%, then that means there's no room for that stent to slip in. Because the stent isn't blown up, it's slipped in unblown up, right, unenlarged, and then they expand it. Well, they can't slip it in because there's no room to put it in there. So they can only place a stent if our coronary artery is less than 100% occluded. So just remember that if your patient has 100% occlusions, they can't put stents in. And so then they kind of go from there to decide what to do. Whether it's open heart and do a bypass, or whether it's like a watch and wait kind of thing, it just kind of depends on the patient and the provider. Okay, so let's talk about our acute MI, life-threatening complication. Number 1 life-threatening complication from acute MI is what? If we don't do anything for it, and it's bad enough, they could eventually go into cardiac arrest. Okay, and then that leads to what? Something I like to call DAD. Stands for, it's really important, write it down, stands for dead, and I know I spelled that wrong, as a doornail, right? We'll say DAAD, dead as a doornail, okay? So it can kill them. All right, how does this happen? Let's talk about how this happens. It's really exciting. So we get some heart cell death, right? Because, why? Because our plaque, right? Nothing can get past it. So then that means the cardiac cells, cardiac muscle isn't being perfused with oxygen and blood. So now we're going to get some heart cell death, if it goes on long enough, right? If we don't fix it. Then it creates, when that heart cell dies, or cells, it's going to create an isolated, this is what I like to call it, island of heart cells that are dead. So now you have an isolated little island that has, we've got some dead heart cells. Well, it might surround an area, and then you might have some okay live heart cells in a certain area. Uh-oh. So now you've severed, eventually you sever that communication from the heart cells, cardiac muscle, to the SA node, which is the master pacemaker, or the master conductor, if you will. So he's got his baton, he's on the beat, right? He's telling all the heart muscle when to contract. Uh-oh. Now you get some rogue guys that are off on their own because some of them died next to them, and so now they're not connected to the SA node anymore. That's bad, right? So now we get isolated, let's see, we get our little island heart cells. So we got our little island heart cells, and they're going to be beating away from the pacemaker. Oops. Now you get, some are beating now, some are beating now, so right? And then eventually what happens, the heart is doing a major quiver, which eventually leads to, when the heart is quivering, that is called what? It's a funky rhythm. It just looks like kind of a garbled nonsense. There's no recognizable P waves. There's no recognizable really anything. And it's called V-fib or VF, okay? Starting to kind of come back to you from BLS class. Now we get stroke volume and cardiac output. Where are those guys left? Do they have any? Well, if the heart's quivering, it's not pumping. And if we're not pumping, we don't have stroke volume or cardiac output. They gone. They toast, right? So now we're in cardiac arrest. Ah! Oh no! Cardiac arrest, what do I do? What do I do? Hurry, run around in circles. Run around in circles, that will help. No, 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 no. So you know, because you're a nurse, so you're gonna know what to do, all right? So we are going to do one thing first. You could do either one of these first because one might show before the other. So you look up on the monitor, what's the monitor doing? That might be a way you're recognizing they're in what I like to call a weirdo rhythm. Weirdo rhythm, weirdo rhythm. Okay, that's not good, right? Which is V-fib. So you're gonna look up on the monitor and be like, is that real? Is that rhythm real, right? It's gonna be dinging along. Or, if you don't have them hooked up to a monitor, you might notice their LOC goes away, otherwise known as becoming unconscious. So they become unresponsive, right? So then what do? Now they're unresponsive. They got a weird rhythm. Now what do? What do you do? This is where you get to do your triple T and shout. So we go tap, 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 and shout. Okay? So that's a 1, 2, 3, shout. Are you okay? 1, 2, 3, or are you there? Okay? You can say any of those things. Hello, are you in there? Right? Tap and shout. Okay? Okay, so, and it's not a nice tap. You kind of have to, do it sort of aggressively so that, we can possibly wake them up. Then what do? If they don't respond, we call for help, otherwise known in the hospital as a code blue. Usually there's a button right up above the head of the bed. Code blue, push it. If you can't find the button, then yell, "Can I get some help in here?" If you say that just like that in that tone of voice, you'll get lots of friends running, okay? But don't leave the patient, stay with them, just yell, "Can I get some help in here?" Right? Then what do? We start. You can do this to staying alive, or another one bites the dust. We do CPR, yay, CPR, right? Okay, and then there's a whole slew of songs of the right tempo for it. Then we gotta do something. We gotta do it, or they're gonna die. Because every minute that you delay doing this really important thing, they lose 10% of their mortality rate. It declines 10%. Okay, so we gotta do this. We gotta defibrillate, right? Okay? That's like the little paddles that they show on Grey's Anatomy. We don't use paddles anymore, right? We just use the pads that stick on the person front to back or front and down here. And then you charge and shock, right? Okay, so when we are just BLS certified, we use an AED, right? Until the ACLS code team arrives. And then, once you become ACLS certified, you are the AED, and you decide what rhythm needs to be shocked. It's kind of fun. So then, after we defibrillate, we continue CPR. No interruptions. No interruptions, right? Okay, and then we assist the code team. All right, that is the end of the video. Good job, guys.